Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I have a very special guest, Eric Bauer from FlightBridge ED.
Hallelujah. Hey, how are you, Dennis?
Hallelujah. 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 How are you doing today, Eric?
Hey, I'm good. I really excited to be on your podcast and really appreciate the invite.
So if this is the first time on our podcast, would you please give everybody a little bit of background on yourself?
Yeah, I've been in EMS fire in some way for now 31 years, and just have had a truly amazing career. I feel, been able to do a lot of things. Started a podcast. It was the earliest critical care pre-hospital podcast back in late 2011, early 2012, called the FlightBridge ED Podcast, and that's how I got into the podcast realm and dove in really with 2 feet, and have really enjoyed the ability to educate people around the world in different ways and meet new people. Love what you're doing. Just want to say thank you for your service. Thank you for all of our military and what you guys do day in and day out. Truly indebted, and I'm very honored to be on this show.
Well, I definitely appreciate you for my service, because it was a lot of fun, definitely, and all for free for me. But what today I would like to talk about is anaphylaxis, and I think the best way to really explain this pathology is with a scenario. So it's not going to be a tactical one. So we, let's say we're in Africa somewhere, and we are training local police. We have a couple of ranges going on. So we have a machine gun range, we have a flat rifle range, and we're just getting things sighted in and kind of feeling each other out. So we got some very energetic young men in the local police force, and they want to show us what they got. So one of them flops down, puts his machine gun over top of a dead log, and just commences to laying scunion down on this little hillside. And in that midst of all that noise and vibration, some hornets start coming out of this nest that nobody knew about, and just commence to covering him with bees and bee stings. So in that, and obviously everybody starts freaking out. Somebody's with a branch beating the bees off of him. Somebody runs over with a fire extinguisher and sprays this guy down with CO2, so that kills a lot of bees and suffocates a lot more. Initial impression from the medic is we have a very anxious patient in lots of pain. He says his skin feels like it's on fire, and we start having hives develop on the flexor surfaces. He's got patches of hives all over, bee stings everywhere. So kind of like your initial impression when you first running on to a patient who's kind of presenting like this, what are your first things that you want to get control of?
Yeah, this is one of those cases I think that we highlight often in training because I think this is really a lower frequency type of a call, right? We don't get a lot of these, and so in a lot of cases the anxiety is a little higher. You definitely have a patient, as you said, that is uncomfortable, exhibiting some anxiety, and I think that's key. What you said there, there's no substitute to recognize through that initial assessment that you have a patient that has some anxiety. And we always say, that anxiety should always be looked at as hypoxia or some type of respiratory involvement. Doesn't mean that it exists at that point, but we should have a high index of suspicion that is present. I think we could all reflect and say if we were stung multiple times by, hornets or yellow jackets or honeybees, that we're going to probably always, or all of us are going to be a little bit amped up. So I think you just initially have to go through and you have to assess and make sure that the patient has a patent airway. How is he breathing? Is his rate elevated? Do you hear anything audible, right? Are you already hearing audible wheezing? Is he exhibiting any outward signs that he's in distress? And I think from that standpoint, you can walk up. And I think most of us that are experienced pretty quickly are able to walk into a situation like that, and you're able to assess a patient without even putting your hands, listening to lung sounds. You can get a good gut instinct of how sick or not sick the patient is.
Okay, very good. So in this case, we know we have the hives starting to develop. He is coughing occasionally, but is that because of the dust that was kicked up when they were beating him with a branch, or from the CO2, the fire extinguisher that they sprayed him with to get the bees off? To be honest, I don't know right now.
Okay.
So this, at least from my experience, this can go like a couple of different ways. You could have a mild allergic reaction, give him some Benadryl, he sleeps it off, and we make fun of what he looks like later on. Or this can become really dangerous really quickly. So how do I kind of determine which direction is it going to go? Like, what is happening?
Yeah, no, that's a great question. I think that the thing that we have to also quickly realize is or assess, is there any past history of an allergen to bees? That's going to, I think, definitely raise our index of suspicion that this could progress into something more than just a standard allergic reaction where they might have some hives or reddening. And my comfort level on an anaphylactic patient is always if there is respiratory involvement of any kind. I'm probably pretty quick to start hitting down that pathway in that algorithm to where I'm not going to go more the standard comfort route, but I'm going to go more aggressive and make sure that we get ahead of this, be proactive, and not reactive in this situation.
Okay, makes sense. Would you say that you're more likely, or you have a very short trigger to start treating anaphylaxis? I guess if you start giving epi, how bad could it go on somebody who didn't actually need it?
Yeah. I feel like if somebody just has simple hives, that's definitely not a case where you're going to start down that road. With that being said, I think you also have to evaluate if you have the means and the equipment to do so. What's this patient's pulse? What's their blood pressure? A true anaphylactic reaction doesn't always elicit a respiratory response where you're going to have stridor or wheezing or a labored breathing pattern. You could have profound vasodilatory shock that you need to treat. So, I think that's more of a new thought process where we've always been taught to focus on respiratory involvement, the wheezes, the edema, the swelling in the upper airways. So I think you have to go through your ABCs, evaluate that. I think you got to listen to lung sounds. If I listen to lung sounds and I hear any type of edema, rhonchi, wheezing of any sort on a healthy person like that, then I'm going to go down the epi route.
Okay, makes sense. So I guess what is happening? What's causing all the wheezing, the rales, the rhonchi, the vasodilation? Like, why is this happening?
Yeah, so I'll try to keep this as simple as possible. I think that the key thing here is that we have an allergen. The allergen is what the sting, and that allergen could be a new medication that you're on. It could be anything that enters our body. Maybe it's entered our body in the past, and our body has marked that allergen. But essentially, it gets processed by a large cell called a macrophage cell. That cell then transports that allergen to a T cell. So, and that is really where a lot of amazing things happen. Our body really starts putting out cytokines, and a cytokine is what's called a interleukin. There's 5 types of interleukins, and the one that we really want to focus on is interleukin 5. That interleukin 5 essentially will stimulate, and it essentially will make an antibody called IgE. And that IgE antibody gets transported and attaches to a mast cell, or what's called a host cell. That is what is now sitting, waiting inside our body to have another foreign invader, that same antigen, or I should say, antigen, enter our body. It recognizes that. And so based on each of us might have this from birth, right? Some of us have an allergy to a specific toxin or bee sting without ever having that introduced, right? But a lot of times that's not the case. It's something that happens over time, and we can then have another bee sting or multiple bee stings where that then causes just this profound inflammatory response where all of these cytokines are then released. And that's what really, really causes the problem. So we have what's called leukotrienes and histamines, and those 2 types of responses basically cause havoc through our body. The histamine response is what we really focus on. Histamines are going to act in 2 different ways. They're going to act on our respiratory system one way. They're going to act on our vascular system another way. Our vascular system, it's going to vasodilate and stimulate vasodilation, which is then eventually going to cause fluid leak or fluid creep, right? And it's going to cause edema. So we have now a very wide open container, the same amount of volume we had previous in the very beginning stages, but we have a container that is super wide. In contrast, it's going to cause vasoconstriction of our respiratory system. It's going to cause edema and swelling to our glottic, our tongue, our lips, our eyes, and that's where you're going to start having that progressive worsening, where you could have stridor and complete airway occlusion. Obviously, every patient is going to progress a little differently. I've never personally had an anaphylaxis patient progress to stridor or progress to complete, profound respiratory death. I've never had that. I know it happens. I know it can happen in seconds in certain circumstances. So, in a nutshell, that is a really quick breakdown of really what happens behind the scenes. And, obviously you get stung by multiple bees, yellow jackets, hornets, whatever it is, right? Those are a lot of foreign invaders. And so that's what really, really you have to worry about in this case.
So you mentioned it can happen in seconds. That's incredibly quick, but I guess how soon should we, if he's going to be anaphylactic, how soon can it happen? Like from bee stings versus like a food allergy or something like that? Are we talking minutes? Are we talking an hour?
So I know of a case, and I know it personally. A colleague of mine had a close friend that I don't remember how it exactly happened, but it was a latex allergy. And from the time of contact, they found her with the EpiPen in her hand, and she was deceased. Like she had complete airway occlusion within the time that she got her EpiPen out. She couldn't even give it to herself, right? And she passed away. So, there are extreme circumstances like that. I have never had a patient like that, but I know that there are circumstances like that with peanut allergies and things like that. There are patients out there that are really, really brittle. So yeah, it could be within a minute of a patient having a sting like that. And I would hope that a patient in those patient types, they're very aware that they have an allergy of that magnitude, right? So I think that it comes down to can you get that information,
Right.
or are you already late to the game? I think you find somebody with, walks like a duck, quacks like a duck, right?
Right.
You walk in, there's bees all around or bee stings, and then that's probably what's happening. And I still think you should try to resuscitate and give the epi and continue through that algorithm, but you're really fighting an uphill battle.
Yep, absolutely. So speaking of starting treatment, of course, first line drug is going to be Benadryl. What are your thoughts on that?
Yeah, I'm gonna say that is absolutely incorrect, and I think that the key here is that's a very common approach, right? And I know you were kind of guiding me to that way, right? As a teaching point, you very well know that that's not the approach, but why do we do that? Why do we see that? I have seen that over and over and over. That is a common scenario we give in testing situations, and it seems like you can give every clue that this is an anaphylactic patient, and they will start with Benadryl, right? I think there's an apprehension out there to give epi like that, and I don't know why, right? I think individuals have to understand the severity of the situation, understand that Benadryl. I had a doctor tell me Benadryl is a medication that makes you feel better.
Yeah.
And it's because the patient's not going to be complaining that they're itching anymore.
Right.
And I had to chuckle because that's absolutely correct. So, I think that Benadryl is a nice option, but that should be the very last thing you think about. That is not going to save the patient, and we should be immediately going to our epi, right? And we know that it's changed. Do we give sub-Q epi anymore?
I do not.
The answer is no. Answer is no. We've seen a lot of changes in this area, and so really the thought process is, and it makes total sense. You need to give your epi as deep and in a place that has the most blood flow, and that is the anterior thigh. And so we need to be given our 0.3 to 0.5 milligrams of 1 to 1,000. If you carry an auto injector, then whatever is in that auto injector from a dose standpoint. But really from an adult standpoint, adult male, if you have a smaller, petite, 100-pound adult female, I'm probably going to go 0.3. But you and I, we're going 0.5, right? In an anaphylaxis, there's no reason that we should not be going 0.5. And I'm reassessing that patient every 3 to 5 minutes, and I'm going to redose. And we got to continue to think about continued resuscitation in these patients. That's the key. We have to throw everything at this situation.
Yeah, absolutely. I mean, if you don't get ahead of it, it's gonna just suck up all your epinephrine, and you're never gonna really accomplish anything. Now, I know sometimes, especially if response has been delayed because of travel or whatever the reason, time has elapsed between the medic and arriving at the patient. And that longer that period of time is, I wouldn't say refractory to epinephrine, but sometimes it's going to take multiple doses to actually get where you need to go. So let's say I do that first dose of IM epinephrine. How long before, and I'm not really getting the response that I think I should? How long until you redose?
Yeah, the standard of care is 3 to 5 minutes.
Right.
Yeah, so I would have another dose ready to go. I don't know from your standpoint in your environment if you carry auto injectors or if you're carrying multi-dose, 10 mils of epi 1 to 1,000. You're having to draw that up.
So usually
lots of ways to do that.
We have auto injecters, and at least in my experience, we'll have the 1 to 1,000. Just the small 1 ml vials. And then with that, you can do IM injections, or you can come up with a push dose Pressor, or you can ultimately go to a drip as well if you know how to do it.
Yeah, love that. Yeah, so you're storing that in a way that you can use it for a multi-use situation,
Yep.
which makes sense.
Yep.
Yeah. Yeah. So I think is it three doses, and then I would evaluate what is happening. At that point, I'm going to probably be thinking about an epi drip. And I would hypothesize that if you have given 3 doses of 1 to 1,000 IM in a healthy soldier that has probably great vascularity in their quads, if at that point you still have a problem, you need to be thinking about airway management.
Yep, absolutely. So, NPAs are one thing. Also, keep in mind, we really don't have much as far as oxygen goes. Rarely do we see oxygen tanks running around on vehicles, fire hazard. But we do have oxygen generators, but they're, as far as output goes, they're generally pretty small. So you would definitely have to optimize that patient positioning the best you can, potentially PEEP, and just giving all the oxygen you can scrounge up.
How much FiO2 are you giving if you're using an oxygen generator like that?
To be honest, I don't know. Usually we'll put it on a face mask, occasionally a nasal cannula, but usually a face mask, probably from my BVM, and just attach the oxygen to the BVM, hold it on the patient's face, and let them breathe through that.
Yeah. Yeah, no, I love that. And I think you brought up a really important point, is the PEEP, right? You have an airway, as we said, that is being attacked by these histamines, and you have vasoconstriction, but you also have edema and swelling, and you also have your vascular side, your capillaries are also being vasodilated. But remember, we started saying that you're going to start having capillary leak. And so what is that doing in the lungs? Your alveoli are now starting to be, surrounded very similarly to what you would see in pulmonary edema or ARDS in more profound states. And so that PEEP is going to be so important in really making the surface area for gas exchange larger and help push that fluid back out. And so that's so important. And I think we don't use enough PEEP.
Yeah.
Right. We need to be more aggressive with PEEP.
Yeah, absolutely. What are your thoughts about advanced airways? So our advanced airway is going to be a surgical crike. We don't really get as much training, I think, is necessary to make intubation really realistic for the majority of people. Like we train with the mannequins and things like that, but I think guys believe that's what everybody is like, and it is absolutely not. Those are designed to make you feel good. So surgical crike is going to be probably our go-to advanced airway. When would you kind of pull, when is your kind of line in the sand as far as I'm going to pull that trigger and put in an advanced airway?
Yeah, no, and I think there's 2 perspectives there. Obviously, you guys have a different perspective. I completely understand that. You're going to go to that method. I think, again, it comes down to what I said in the very beginning, is you have to be proactive, not reactive. And not only do you need to be that way with anaphylaxis, because in a blink you can be way behind, but with advanced airway management, there's a really big push in. We need to slow our thinking down, but that doesn't mean we need to pull back on that. We need to make good clinical decisions. We need to be proactive in our decision making. And I think it comes down to, you have to look at an airway purely from 3 standpoints. And what I always teach is, can they follow your commands? Can they control their secretions? And this is the big one, what is their clinical course? If their clinical course is not good in your mindset, or it is based on maybe how you're going to evacuate that patient, or there's a lot of decisions that come into it. May not be at that moment they completely cannot protect their airway, but What about in 20 minutes? Right? Are you going to be in a situation where you're not going to be able to manage the airway the same way? It's better to do it now. So I think there's a lot of decisions that have to be considered with you and your team to do that. But I think as long as you have a plan and you're able to manage that patient, again, sometimes taking control of an airway like that gives you more freedom to manage the patient.
Yep.
Big responsibility to do that. You know what? It's not a decision that should be taken lightly, but I think I see more issues with whether you're talking about paramedics or flight crews or whoever you're talking about, military, maybe being a little too cautious and being having that inaction.
Yep.
Sometimes inaction is not the best approach. I think sometimes it is, but in this situation, I think you got to be very direct in what you're wanting to accomplish and accomplish it.
Yep, absolutely. So we talked about, IM epinephrine. Okay. Probably IM routes first. I would assume after you've given your IM injections, your next course of action is to get IV access. What do you?
Yeah, absolutely.
Okay. And then would you start going to IV like push dose types of pressors, or do you like drips, or does it matter?
Yeah, so that comes back into what we started talking about. What is the patient's blood pressure? If you don't have the ability to truly check a pressure, right, just check their pulses. What are you getting in your 3 pulse areas? And I know it's not a perfect science, but it gives you a good indication of where you're at. And I would just assume that patient is potentially hypotensive. What's their pulse rate? How is their cardiac output? I think when you look at the patho and the vasodilatory effect that you're going to see with that histamine release, you got to remember also that we're going to have a drop in pressure, which is going to cause a drop in cardiac output. So the second ingredient, the prime thing that really allows us to oxygenate, we can deliver all the oxygen we want, even at 21%. If you don't have the engine behind it that's going to deliver it, we're in trouble, right? So it takes both the oxygenation, even from an atmospheric 21%, got to have the horsepower behind it. So we got to get control of that. We have to get that IV access. We have to start volume resuscitation. And, I really think it's important in this situation. We talked in the pre-show area that, there's definitely a mindset right now in sepsis to be more cautious, not to overload our patients. We're seeing the same thing in burn patients, seeing the same thing in trauma, right? We have way overdone it in fluid resuscitation, specifically normal saline, and we know that there's definitely iatrogenic causes of mortality because of that. So, but I don't think that's the case in this. This is completely different. This is an acute vasodilatory response. We have to fill the tank. I'm not saying that you immediately drop 10 liters of fluid,
right?
And I would probably say you don't even carry that. Do you guys have volume expanders that you carry outside of colloids? Blood, yeah. So, do I feel like blood is probably the right approach? Probably not, right? Yeah. Right. So, I think you have to do, there's definitely differences in the austere environment than what we would maybe see in our environment. And so that's where you guys might go a different approach. The surgical airway approach, that would be looked at in the public view, is more of an aggressive approach.
Yeah.
But I completely understand why you go that approach. It's based on your environment and what you guys have and the speed and yeah, I get it completely. So yeah, if depending on what you had available, I'm not opposed to starting going the push dose pressor route. And starting an epi drip to try to get a little bit of squeeze and improve that perfusion status as much as possible.
Okay, so I mean we do carry crystalloids as well. I would say in my bag I probably have roughly a liter in my bag between some 250 bags and maybe a 500 bag. So obviously I can get their blood pressure probably as high as I want with enough epinephrine. So where do I kind of make that transition between my push doses, either my push dose or my drip? So with my epinephrine squeezing the vascularity down and my volume expansion, like what are my goals for, I guess, either?
Yeah, I would focus on just standard of care goals. So I would say, do I have a map of at least 60? I think we're talking about healthy individuals, so
Yep.
I wouldn't try to overdo it. 60 we know is at least you're getting perfusion of the kidneys. And are you starting to see that heart rate respond? Now, with that said, we've just dumped a lot of epi into somebody, and so they're definitely going to have a response to that epi, and so I would not use that heart rate as a definitive, but I would just it's not going to be instant either, right? And we haven't even discussed. You definitely could see a lot of improvement with everything you've done, and 30 minutes later have more of a rebound effect, right? That happens in severe anaphylaxis all the time, where you have a rebound response, and it seems like you have another huge histamine release that you might have to deal with again. So I think you have to be ready for that.
So let me see here. All right, so we got our epi on board. We're at least monitoring his airway, maybe doing some kind of positioning, maybe getting some kind of oxygen going. We've got our IV access with some, a 500 bag of LR or something like that. When do the histamines, the steroids, things like that, when do they come into play?
Yeah, I feel like once you have given your epi, right? You've given your epi, you start seeing an improvement. We've managed our life threats. We've managed the airway. It's secure. Obviously we haven't even talked about, post airway management, right? Whether you're using an advanced airway or surgical, or how are you managing that from a sedation standpoint? What medications are going to be best for this patient? Obviously, ketamine is probably going to be the best option in that situation. But as we said in the very beginning, Benadryl is going to be a drug that is not going to be, it's not going to be that initial, but I'd say that's more that secondary treatment, right? These are things that, all right, now I can start thinking about, hey, you know what, let's start some Benadryl, which again, is the patient going to immediately feel that? Well, if they're conscious and alert and awake, they might. If they're intubated, probably not. But then you start talking about the steroids. The Benadryl, I'm going to go 50 milligrams. If it's a pediatric patient, I believe the dose is 2 milligrams per kilo in most cases. So, I think the very quickly you get up to that max of 50 milligrams. And then really it comes down to the steroid, discussion. Solumedrol versus dexamethasone. Which one do you guys carry?
Dexamethasone.
Yeah. And I'm glad. And I think the thing is that a lot of places in the public sector, they probably carry more Solumedrol. Is there a difference? Well, they're actually the same drug.
It's the concentration, isn't it?
It's just higher concentrated.
Yeah.
So from a long-term standpoint, really why it's more advantageous to use dexamethasone is it's more the half-life. The half-life is so much longer that secondary treatments, where maybe that patient would have a prescription of prednisone after they were discharged, doesn't need to happen because the dexamethasone's half-life is so long. Whereas in Solumedrol, very short half-life. But I think the thing to understand with both of those is, as we talked about in the pre-show, is the onset of those are not going to be immediate. You're not going to see the effects of those for a couple hours,
right?
In a lot of cases. So again, I think it's looking at the future and dealing with the future, but we have to maintain the thought process of the present, right? We can't control the past. We got to be in the present. Think about the future, but don't let it consume us.
Right. What about like H1 blockers like retinidine or things like that? I know nausea is a big thing with anaphylaxis as well.
Yeah. So, H2 blockers, really the reason why, and this is something that a lot of, I don't remember learning this in initial paramedic school, but, we build a lot of acid in an anaphylactic reaction, right? And when that acid production causes the nausea. The thing about Zantac, as you mentioned, Zantac is no longer an over-the-counter medication. There was FDA pulled that. So that in the podcast that we discussed in the pre-show, right, that was really the standard, was Zantac. But I think nowadays it's Pepsid. Pepsid is going to be the go-to. Tagamet is another one where you could give. And I think, again, that's a secondary or maybe a third line thought process for after maybe you drop the patient off, or if you have a long time with a patient. Again, you guys are in a different situation where you might have extended time with these patients. And so, again, those are the two routes I would go, would be the Pepsid or the Tagamet.
Now, will the steroids or the antihistamines, are they going to at least reduce the likelihood of that rebound hypotension?
I would say that's going to be probably a case by case type of a thing. I think you just have to be ready for it and watch it, and just be aware that it's a potential. Continually monitor your patient and just watch for any clinical signs that maybe something is changing. Do you guys have end-tidal CO2 capabilities?
Yes. Yep. Through the
that's a great
EMA.
way to assess. Yeah. Whether they're conscious or and actively breathing and able to communicate, using a side stream device to where it's going to be the quickest way to identify changes in perfusion. So I love that.
Nice. So when do I start kind of withdrawing or turning down some of these epi-drips? I mean, eventually he's going to start to get over it. The steroids are going to start kicking in. His body's going to start processing the antigens, and hopefully the cytokine little storm that's going on will start to abide. When can I feel safe to start kind of withdrawing care?
Yeah, I mean, I think you have to look at it from the standard markers, right? And again, it comes back to, what do you have available? Are you able to do point of care testing? Or if you get to more of a field hospital that's in your area, are you able to do any type of labs where you can look at, eosinophils and look at your white blood cell count and see what your histamine response is, and look at those things. I think, again, you got to come back to what is normal for that patient. What's a normal MAP? What's a normal pressure? Are you consistently staying there? And if you have an epi-drip going and you were hypotensive and now you're seeing more of a higher pressure, I love that you brought that up. You have to titrate that stuff down.
Mm-hmm.
And I think that's one of the missing pieces that I see, is a reluctance or a fear of adjusting a medication.
Yep.
Right? You have to, just like we turned it up, we got to turn it down. Even DC something if you feel like it's not necessary, and that's okay.
Yep.
So I think you have to just be well versed in your current guidelines and what you're able to do, and have those metrics in your mind. All right, well, what's my norm? Are we close to our norm? Where'd we start from? Where are we at now? And then just make the best decision.
Yep. That's a kind of an ongoing bet I have with my students and when we're doing patient care, is I look at their analgesic drip and I say, I bet you will never turn this down. And usually by the end of the day, the drips just keep getting higher and higher and higher and higher. Because, a calm patient makes you feel very comfortable. And when they're sleeping, that makes you the most comfortable, right? Despite whether that's what you actually want.
Yeah. Yeah. No, it's amazing. And I see that probably more transitioning into more of a prolonged field care or critical care type of a thought process, where maybe as a ground paramedic, you weren't really either with your patient long enough to make the decision to titrate something down. So that wasn't something you became comfortable with. I think nursing, they're very comfortable in that area. And I think when you get into those long field times like you guys are in, or in an air medical environment where you have the ability to have 2-3 hours with patients in some cases on a routine basis, you become very comfortable, but you see a reluctance to turn things down. I see it all the time with balloon pump therapy, where you have a chemical balloon and a mechanical balloon. The mechanical balloon is all or nothing. Like, you're not adjusting that, but their pressures are exceedingly high, which is causing a huge amount of afterload. It's working against the balloon, right? And they have a reluctance to turn the pressors down, the chemical side down. And if they would just lower those drips down or remove some of them, your patient is going to be better off. And so that's just something that I think comes with experience.
Yep.
And you have to have the comfort you have to understand the pharmacology.
Yeah, absolutely.
You got to know that stuff. I think the last thing that I want to bring up on a case like this is something we don't see a lot of, and it's not talked about a lot, and that's called Kuhn syndrome. And Kuhn syndrome is definitely something that could affect any of your soldiers, anybody that is younger. There's lots of case reports that are out there, 16, 20, 24-year-old men and women that have had severe anaphylaxis that go into, a perceived MI. They're having 12 lead ST elevation changes, where they're having ST elevation in, 2 to 3 consecutive leads or contiguous leads, and taken to a cath lab, transported to a cath lab, and a completely clean cath. They do a stress test afterwards, and we just have to understand we've loaded them with a lot of epi. And in most cases, I think you're probably wrong to not look at it and assess it for what it is. But most cases end up being what's called an alpha receptor mediated, vasospasm, coronary vasospasm. And that is going to definitely mimic an MI, right? It's just one of those things. It's a secondary problem that you see. And I just think that you have to be aware of that. That's definitely not something that's taught a lot of. You gotta look at it for what it is. And I think where you probably are more apt to jump on it is an older individual, right?
Mm-hmm.
You have somebody that's 56 years old that does that, but a 20-year-old complaining of chest pain, are we going to give it the same level of attention that we should? Right. And I think sometimes we don't, right? That's the one side of medicine, that cynic side.
Well,
right?
They don't fit the mold. That's not what I was taught. So they're lying, or it's something else. They're nervous. Yeah. It's from their anaphylactic reaction. There's something with their lungs, and I've seen a lot of people, experienced people, junior people, just chase down completely the wrong thing and then start to convince themselves that they were actually right.
Yeah. I mean, I think that we're all going to make mistakes. I think you have to be very, very humble, self-reflective. You have to be self-aware of if something makes you uncomfortable, that's an indication that you're weak in that area, and you should immediately go and try to seek that information out. Mm-hmm. And I know that I've done that many times over my career, and I think that you just have to be willing to do that.
Yep.
I still, as much as I teach, and I've taught critical care cases for 10 years now, over 10,000 hours, but there are certain lectures that I don't teach a lot. And if I end up having to teach them, there are certain sections that I recognize I might not outwardly show it. The student might not know anything different, but internally, the information is not coming to my brain as quickly as I would like, right? There's gaps. Mm-hmm. And I'm self-aware of that, and I don't like that feeling. And I think you have to take that same mindset to clinical practice.
Yep.
Right? We have a big responsibility. We have to make sure we're ready at all times, and it's important.
Yeah, absolutely. And I think, at least for the listeners, just a reminder that there is such thing as telemedicine, and nobody knows everything all the time. Reach out early, especially if you're dealing with a critical patient. Reach out early. Talk to you're going to be talking to an ICU attending who does things like this all the time and doesn't have to deal with the stresses that you do. Let him take some of that burden off. If you just present your patient, present your plan going forward, he can help you tailor that plan and make it a little bit better. Or if you just have a question of like, I've been running this epi drip for 4 hours now, and I'm not really certain if I should be dialing this back yet, he will walk you through it. It's not in there. They're not going to judge you. They're just going to try and help you.
Yeah, well said. Yeah, I mean, I think that comes with age as well, right?
Mm-hmm.
We learn over the years of things that it's all right to not know something.
Yep, absolutely.
Yeah.
Was it for anaphylaxis? Is there anything else that is commonly missed that we haven't gone over?
Not that I can think of. I think we really hit on that really hard. It's the reluctance to go epi.
Yep.
And I think having that in your mind, somebody with simple hives that has no respiratory involvement, absolutely fine with that. But if there's any respiratory involvement, anxiety, increased rate, anything like that, where I just don't think you're wrong to go to that point. If they have wheezes, you need to be going that route.
Yep. Well, thank you, Eric.
Yeah, no, thank you, Dennis. I, again, really appreciate it. Look forward to doing more podcasts. We talked about doing a few together, maybe on the FlightBridge ED side as well, and excited to be able to do that.
Yeah, I'd love to. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.